Thank you. Thank you. It is an honour to be back here again. Minister, distinguished guests, friends, one and all. We gather today again on the lands of the traditional owners, and I respect their elders, past and present, and the spirits of the land itself. May we carry that with us. It is bringing coals to Newcastle, it is bringing tea to China to talk about collaboration in this part of Tasmania. I know that because of a long association with Tasmania. I know that because of my work on the Tasmanian Early Years Foundation. I know that from some of the work I did in 2006 and 2007 in preparation for the child protection reforms in this state, that this region is renowned for its collaboration. So it's with some intrepidation that I come to speak about collaborative practice, because many of you do it every single day, way better than in most parts of this country. The Australian Centre for Child Protection, who has sponsored my participation in this conference, is very committed to a public health approach to child abuse and neglect, and has championed and been a powerful advocate for that since its inception in 2005. We are funded by the Australian government and work across Australia doing research which we help translate into practice and into policy, professional education and workforce development, and last but not least, advocacy, both in the policy area but in the broader public domain. So I'm very pleased to be here representing the Australian Centre for Child Protection. Now, I pull this out and let's go on. I'm going to start with the logo of the Adelaide Women's and Children's Hospital, which long before I was a member of the board of the Adelaide Women's and Children's Hospital, I loved. And one day, in the International Year of the Family, I brought this with me in one of the earliest PowerPoints I did to Hobart. And I used this as an illustration of how we leave fathers out of families. But a man in the back row was not going to have any of it. So I went through my usual patter. Can you see the child? I'd be really, really concerned if you couldn't. Can you see the mother? Can you see them both at the same time? Yeah. If you focus, particularly on that line, and you hold it together, you're holding a mother-infant dyad together, which I think is a nice metaphor, focusing on the point of interaction. And then I meant to ask, can you see the father? And you're meant to say, no, right? And I asked this question in Hobart over 20 years ago, it must be, since the International Year of the Family, I think it must be. And right up the back row, he said, yeah, I can see the father. I said, sir, would you like to come down and show us? I thought, there's no way the Women's and Children's Hospital has put a bloke in that logo. Down he came, and I must emphasise this was a man seeing it. It's not a woman seeing this. I don't want to be accused of being anti-male. He said, yeah, he's there all right. There's his sloping up forehead, his pointing up nose, there his lips, and that's his beer pot belly. So, the moral of the story is, you can find fathers in families, but you've got to want to see them. And sometimes we haven't wanted to see them. Sometimes we haven't wanted to engage with them. Sometimes, particularly as female service providers, we've been relieved when they haven't been at home. In fact, they may have been hiding in the laundry or in the back shed. And gender-sensitive practice cuts both ways. And so we need to think about families with men in them, not just women and children. So that's what I want to carry with us today, even though the family I'll be talking about later didn't have a father, but there was a very significant grandfather. So that's my way of starting, and the moral of the story I've already shared with you. I'm now going to show you some confronting data. That since I spoke at the International Year of the Family in Hobart, the number of children in state care in our nation has doubled. And Tasmania shows the same trajectory as the rest of the country. This is deeply concerning because this is a giant social experiment. removing children on this scale. A giant social experiment. Paradoxically, this is occurring as we've apologised to the stolen generations. Aboriginal children are 10 times overrepresented in these figures. Paradoxically, in the wake of our apology to the UK child migrants, and now in the wake of our apology to the forgotten Australians. The research on what we might be doing to children is very concerning. We have no Australian research that allows us to draw a conclusion about the difference in the harm done to children prior to coming into care and the harm done to children after they come into care. But there are a number of US studies that raise concerns. We can't say it's having the same effect here, but it raises concerns. So a huge data linkage study of 45,000 Illinois children were compared where there was a similar risk level, comparing those who were brought into foster care and those who remained with their families. So for school-aged children, at the time these children were brought into care, which is the 1980s, that's my qualifier, in Illinois, school-aged children on the margin of placement at that time, the outcomes for children who remained at home were much better, with or without any service. Lower adult arrest rates, lower teenage pregnancy rates, and better employment than those placed in foster care. Now, I can't say that that's the effect that bringing children out of home care is having in our country, but the placement instability rates in every state and territory of this nation are appalling. And that corrodes children to the very core of their being. So let us do no further harm, and let us transcend a child rescue mentality and embrace a public health approach. The other reason for embracing a public health approach is statutory child protection systems cannot cope with the demand pressures. 1 in 3 or 1 in 5 children, this is not notifications, this is children. So I'm not confusing this with the data about the same children being notified multiple times. So using retrospective data in South Australia, where 1 in 4.5 children born in 1992 was notified to the Statutory Child Protection Service by age 16. Or using retrospective New South Wales data where 1 in 3 children, now 18 or over, was notified to the Department of Community Services. Or Victoria, where we did some very reliable projections in the recent Protecting Victoria's Vulnerable Children inquiry, which I was on the panel for, where 1 in 5 projected children. A small minority of these are substantiated, an even smaller proportion proceed to statutory intervention. But a paradox of this system is it might be like trying to find the needle in the haystack because of the overloading, if you like, of the casualty department by children who could be seen by the GP, to use my metaphor, and keep with a public health way of thinking. So, when we look at the characteristics of children coming in and out of home care, this is a national study, this is what we find. Massively high levels of parental substance misuse, domestic violence, and parental mental health problems. So 2/3 of the children, why it sums to more than 100%? Because many families have got more than one of those problems. And there are other problems in addition to those. So that tells us that if we want to prevent children coming into care, we must do something about those issues. So we're dealing with families with multiple and complex needs, but we've inherited an old service system which is largely based, and sorry for the bureaucratic language, around single input services based on categorical funding. So not only does one individual with various problems get a service from a whole range of organisations, but if you put that together, the various members of the family might have up to a dozen organisations involved. The Parenting Research Centre in Victoria has a powerful DVD of a father with an intellectual disability who talks about 7 different organisations coming to his door and the door of his wife and their children each week. He doesn't know why they are coming. If I had 7 different organisations, I'd be pretty confused too. So The whole strategy we need to embrace is one of having fewer organisations, but those delivering a broader range of functions to meet the needs of the family. So in many situations, it's actually reducing the number of organisations involved in the lives of families, but broadening the number of inputs, if you like, or the types of responses that they can provide. The challenge of ending child abuse is the challenge of breaking the link between adults' problems and children's pain. That came from a review of child deaths in the Western world, in rich nations. So where do we go from here? It's a long way up. This encaptures for me the way we have to think about our service system reform within a public health model. Of course, a public health model is more than about services. It's reducing the risk factors and strengthening the protective factors at a population level. A public health approach to infectious diseases is not just about hospitals and GPs. It's about clean water, sanitation, and all the things you might have to do with HIV/AIDS, around safe sex, or it's like skin cancer, tackling the hole in the ozone layer. We can't solve child abuse and neglect by services alone. So the most important protective factor is parent-child attachment. What can we do about that? Beyond the scope of my remit today. But many of you work in settings where you nurture the depth of attachment and the security of attachment between parents and very young children. You are strengthening the most important protective factor there is. Risk factors. The single largest risk factor is alcohol abuse. A conservative estimate is that 13% of children in Australia live in a household where they're regularly exposed to parents who are drunk. The solution to that? Not politically easy. Volumetric taxing, minimum price, restricted alcohol advertising, and a massive health promotion campaign around alcohol and children don't mix, just like drinking and driving don't mix. We can't expect politicians to do it unless we as a community are prepared to back it. And there are very powerful vested interests which are trying to stop that happening. We'll get there, but it'll be too late for many children, particularly many children exposed to alcohol in utero. Okay, so leaving aside the things that aren't about services, what do we need to do with the service system? And I'll cut to the chase. Many of you work in these two outer circles where the Communities for Children program has been so valuable in helping pull that together and strengthen those links between the universal services of child and family health nurses, of midwifery, of early childhood education and care, of schools, and GPs, although they're often left out of the equation. The targeted prevention often and best off a platform of those universal services which don't carry a stigma and which are highly accessible. And then with wonderful developments like child and family centres, you begin to see that Tasmania, like other states and territories, has been strengthening these outer circles. But that is not enough, because if we're going to face the challenge of dealing with the adults' problems that cause the children's pain, we won't achieve it only by these two circles. We have to engage the organisations which deal with issues such as drug and alcohol misuse, family violence, disability, particularly intellectual disability, adult mental health problems, correctional services, homelessness. Now I could add problem gambling, I could add refugee resettlement services. There are a whole lot of adult specialist services which have to be part of the solution. So it's how do we not only develop the relationships between the services in these two circles, but how do these services relate to these named services and they with one another around families with multiple and complex needs to stop children ending up in the statutory child protection system and some of those children ending up in out-of-home care, which can, for many children, be doing greater harm. That is a big challenge. But the good story is that we are already making moves to that in most parts of this country. So the challenge will be about building the capacity, particularly of the adult-focused services, to respond to their adult clients as parents and to their children. There was a workshop yesterday, particularly around that theme that Sharon, Katrina and Belle took. I couldn't go to it because I was doing another workshop at the time. But that building the capacity for child and family sensitive practice with our colleagues in these services is a very important strategy, but also building the bridges between the services. And that's particular focus today, but I wanted to put it into this big picture so we understood why it is an imperative. So the Australian Centre for Child Protection, with funding from FACSIA under the COAG, the Council of Australian Government's National Framework for Protecting Australia's Children, we, in partnership with Communities for Children programs in 12 sites across Australia, are implementing the Protecting and Nurturing Children, Building Capacity, Building Bridges Workforce Development Initiative, with two goals, as I've said, building the capacity of adult special service and building bridges between adult services and traditional child and family focused services. This is a big agenda, but we're seeing some amazing things in these 12 sites. Working together can occur across a spectrum from the informal cooperation with no interagency protocols and you just do it because it's the right thing to do. So when I was a social worker in a psychiatry department in a women's and children's hospital in Victoria, I would invite the local child and family health nurse to come and meet the mother recovering from an acute postpartum psychosis, to meet her and the baby, as we'd pioneered the joint admission of babies and their mothers in a psychiatric setting, to meet that mother and meet the baby before that mother and baby were discharged home. There was no protocol, there was no procedure, and it worked really well. And that's what you do every day. Most of the collaboration is at that informal level of simple cooperation, and you know what you need to make that work. It's relationships. It's relationships, and that's the goodwill is the oil that turns the wheels. Then we have coordination, which is more formal, where our organisation may have a formal agreement with another about how referrals are to be made or about how you are to collaborate. And a lot of our working together is at that level. And the last one is more formal again, and I think Gateway would probably be a good example of that, which probably works in a similar way to the Victorian Child First initiative, where we have in Victoria a community-based statutory child protection worker outposted. I'm not sure if that is quite the model here, but it's where you've got actually the bringing together in a new form elements from existing services. A good example of that in the mental health and drug and alcohol area would be specialist services for dual diagnosis clients under the one roof. So you don't have mental health there, alcohol and other drug treatment services there. So you're creating, in a sense, new, not necessarily new organisations, but new organisational forms. So that's the continuum. And all the time, people are urged to work together. Every child death inquiry that I've been on or read ends up with recommendations about people working together and about collaboration. And certainly every child protection review and inquiry comes to the same conclusion. And sometimes you get the feeling that we are being told that it's a simple thing. We just have to join everything up, work together. If it were that simple, we'd have already done it a long time ago. And I sometimes think that when we're exhorted to work together and collaborate without recognising the really major built-in obstacles to achieving that, then it's a bit like saying to a very troubled family, why don't you just try being nice to each other? It won't work. It won't work because there are real barriers, and these are real barriers that some of you, I guess all of you, struggle with and overcome as best you can every single day. I want to go through these because it's a way of analysing the challenges, and it's a way of then thinking about the tailored strategy if you can identify where the source of the problem is. So I want you to think, if we were in a smaller group, I'd ask you to talk to the person next to you. I want you to think about a recent conflict you've had with another organisation. Anyone not able to think that? Okay. And I use the word conflict really deliberately because many of us are averse to, are afraid of conflict. And we need to understand that conflict is completely normal, but it can also be dysfunctional. So conflict is embedded in the nature of the beast. You can't have a family without some conflict. You can't have a workplace without some level of conflict. You can't have interagency networks without some level of conflict. The issue is, how do we use that conflict constructively and prevent it becoming destructive? And so for an organisation to interact with another organisation, and ultimately, of course, organisations don't talk to each other because they can't talk. It's people who talk to each other from different roles. An organisation that invests in working with other organisations puts at risk its scarce resources because collaboration is costly in time, and it puts at risk its autonomy. So there's an inbuilt tension around collaboration, as the organisational theorists would say. So it's not surprising then that it's not easy to do this. It's not like just being nice to each other. So I want you to think about that recent conflict you've had, or a really old one that might be particularly powerful in your mind. And I want you to think, as we go through these 5 levels, whether one of these levels is relevant to the nature, to the understanding, the origin of that tension. And it might be that you can identify several levels. And it might be it starts at one level, but it sort of gets onto another level. And if we were able to use a framework to sit and analyse it, we would engage our heads more and be able to develop the strategy, individualised strategy, for this particular conflict at this particular time. Or it might be a tension, it might not be a conflict, it might be low level. So at the interorganisational level, given that organisations are driven to conserve their scarce resources and to preserve their autonomy, it's not surprising that many organisations, for survival reasons, need to engage in gatekeeping. You know what it's like to try to get a family or an individual client through the door of an organisation you're trying to refer into. You know what it's like to have that gate slammed in your face. And some of us also know what it's like to have to close the gate. In a system we have in child protection in most parts of the Western world, where mandatory reporting is in existence, the threshold for making a report is down here. The threshold for bringing a matter before the youth or children's court or even investigating it is up here. There is an inbuilt tension between those 2 levels of trying to put into a system, and a system under massive demand pressures, but also, of course, under certain legal restrictions, not accepting many of those referrals. So the interorganisational level is not about you, it's about the structure of the service system and the dynamics that occur in a field of chronic scarce resources where there are factors that make it difficult to be able to give and receive referrals, or where one organisation, for example, is defining the adult as their client. If I'm an alcohol and drug counsellor, Do we have anyone from the alcohol and drugs sector with us? Well, I'll pretend to be one. I'm on the Australian National Council of Drugs, so I have to learn to pretend these days about what it might feel like to be in that role. I might have a very fragile client who doesn't know whether they want to see me, who's terrified if I ask questions of whether they even have children, that I might pick up the phone to child protection. So I'm very concerned about how child welfare services may actually be putting additional pressure on my client, because I don't want a relapse to occur. And now they want me to say what's happening every day with my client, who doesn't know whether they want to see me. She's terrified of losing her kids. But over this side, in the child focus service, how can I think about returning children home unless I know whether that situation is safe? So I come from a very different perspective. I've got a different client in my mind. One a child, one an adult, and we struggle in the middle to try to work in a family-centred way. So this interorganizational conflict is built into the specifications of our service system, and there are major ethical issues and clinical issues that make it very difficult, where confidentiality is a respected value to make it a safe clinical service, but where the lack of information exchange can at times be very dangerous to children, and where the most important protective factor for a child might be that their parent with an alcohol and drug problem trusts their alcohol and drug worker. This is not new to you. This is the bread and butter of working with vulnerable families with multiple and complex needs. So I wonder if any of you thought of a conflict that was primarily at that level, that structural level. You put up your hand if you think the conflict you were thinking of is of that nature, about scarce resources, who the client is vis-a-vis each other, gatekeeping. Was it, anyone had a conflict that was like that? Yeah, right. And they're hard to solve at the direct service level because they are related to broader issues of policy and funding models and our fundamental definition of who is our client. The intra-organisational level is a very interesting one. This is where, in addition to the inter-organisational factors, there are dynamics within an organisation that actually make it hard to work with another organisation. You can usually tell by listening to the conversation in the tea room. It starts like this, and we've all told these stories and we've all listened to them. You won't believe what they've gone and done now. And then the atrocity story. And the narrative's always the same. How stupid they are. And we tell these stories, partly because we need to ventilate and debrief on them, but partly because it allows us to then feel a greater sense of cohesiveness. We sometimes tell these stories in our agencies, upstairs, downstairs, that program, that program. So we get an internal cohesion by having a common enemy. This can happen on a whole nation against an ethnic minority or another minority. It can happen between nations. So cohesion against the common enemy is a very powerful force and can be used politically and internationally in very destructive ways. And every time we tell an atrocity story, we reduce the social capital which is required between organisations to work together. We tell atrocity stories to our new staff who've yet to set eyes on the person who's the other. And we've already poisoned their capacity to engage with that person in the other organisation. So let's be very mindful about whose interests are being served when we tell and listen to atrocity stories. And who's caught in the crossfire? Vulnerable children and families. So there are some dynamics inside organisations that need to be challenged. Challenged from above, challenged from below, and sometimes leadership has to change because this is incredibly poisonous. So what are we going to do about atrocity stories is an important question. At the interprofessional level, this is a bit like an intertribal experience. So we've been socialised into our own professional perspectives in terms of our values, our knowledge, our skills. We have a sense of personal identity tied up with this. And now we've got to interact with another profession at the same time as we're interacting across organisational boundaries. It's hard enough working with these other professions when you're in an organisation with a multidisciplinary team, like in a hospital. But at least you've got a clear hierarchical structure which can sort of make you work together. And I've worked in some brilliant multidisciplinary teams where we've really understood that the whole is so much more than the sum of the parts. It's very difficult when you're crossing organisational boundaries and professional boundaries at the same time. I once did a study of child protection case conferences, and we interviewed every participant, including the parents. Before the case conference, they allowed us to be present during the case conference, and then we interviewed them afterwards. And I remember interviewing one police officer, and we had a police officer with us yesterday, I'm not sure if we do today, and he said to me, a social worker, he said, the problem is social workers talk, police act. Speechless social worker. What could I say? Verbose social worker. And then as he spoke more, but not very much, it emerged that he also had a very different understanding of the unwritten rules of the case conference, which the others were completely oblivious of. So from his perspective, think coming from that service, he saw the person chairing as in a leadership role to hear from you, and you, to sum it up, and then to confirm what you, and you were doing. That's a slight stereotypical exaggeration, but he was used to a much more directive process. The others at the Child Protection Case Conference were trying to get consensus, and they were mostly women. And so they needed to talk about their feelings. And so they went around in a few circles. And that drove him crazy. The health professionals were very wary of sharing all information. And they were much more cautious about hypothesising about things for which they didn't have hard data. You'd expect that. So we sometimes have even different rules about how to relate to each other when we cross professional boundaries. I'm wondering whether any of the situations you've been thinking of might primarily be interprofessional. Any? Different professional perspectives, yeah? Recent study at the Australian Centre for Child Protection, where one of our clinical psychologists has done a wonderful PhD looking at how youth workers, child protection workers and teachers and foster carers all make sense of a child's challenging behaviour. Really different constructions. So trying to understand where we're coming from. You notice I didn't ask if any of you had a problem that relates at the intra-organisational level. I didn't want to out anybody. Okay. Interpersonal level. You know within 10 seconds of picking up the phone or seeing someone whether this is going to be chemistry that's going to work or not. There are always interpersonal issues. But we often experience interorganisational conflict as if it is an interpersonal issue when it really isn't. It's really something else. The test for that, so I want you to think about that situation in your mind, is if you were to have swapped places with the person you're having that conflict with, and be in their job, and they're now in your organisation with your job, would you be having the same conflict, but from the other side of the fence? If the answer's yes, you haven't got an interpersonal problem. It's much more likely to be of another source, particularly the first, I suspect. So we can overestimate interpersonal. It's the interpersonal, when it works well, that makes us cope with all of that. This is why we get, I think, a superb level of collaboration in a service system which doesn't really deserve the level of collaboration that it gets. It's because of the goodwill, particularly in rural communities where people know each other and there are dense social networks which connect. It's because we are prepared to use the interpersonal to counter the structural. But we can't do that when it's intrapsychic, when the source of the conflict is really deep within us. So in my PhD that looked at, among other things, interagency conflict in child protection in Victoria in the 1990s, when I looked at cases where the conflict was white hot conflict, where even now, all these years later, if I bump into a paediatrician or one of the child protection workers or one of the other staff involved, they still want to talk about it. They still want to debrief on that. Then it seemed to me as if we were dealing with something that was of quite a different order. That they were dealing with, I don't want to get too psychoanalytic about this, but they were dealing with their own feelings about having failed that child. That they couldn't save that child. They couldn't rescue that child. And they were projecting onto the other organisation a distorted and exaggerated capacity to save the child. They were displacing hostility onto the other because they had more deeply felt they'd failed the child, particularly in situations such as chronic neglect, where nothing was making a difference, or seeming to, or in cases of suspected child sexual abuse where there was insufficient evidence for anyone to act. These situations cause enormous anguish. And when anxiety levels rise, whether it's about a risk to a child or a suicidal risk, those defence mechanisms come into play very powerfully. That's part and parcel of working with vulnerable families. So how does supervision, clinical supervision, something which I talked about yesterday in another context, or professional mentoring or a sounding board for reflection on one's practice, not supervision as in being told what to do, how does this help us deal with those various sources of interorganizational conflict, from those that are structural right through to those that are intrapsychic? Well, I'm not sure if most supervision is paying attention to this. Some supervisors do, but sometimes very hard for supervisors because they're team leaders, they may be team managers. Remember, they're protecting the scarce resources of the organisation, they're preserving the organisation's autonomy, they're actually managing the size of your caseload sometimes, and they may have their own issues with the other organisation. So sometimes the clinical supervision may not be able to help the worker address the interagency conflict, to stand back, to reflect, and try to then say, well, if that's the source of the problem, can we acknowledge that? And can we then address that in some way? So what I'm asking supervisors to do is to use a framework like the one I've just described with those 5 levels or something else to intellectually be able to look at this interagency conflict, to not get so enmeshed in it, and to provide a sounding board for your supervisee to reflect upon that, just as they would look at issues to do with their relationship with the family and try to unpack that and develop their own strategies for dealing with that. It might be the supervisor also has to manage up, because particularly if they're seeing this as a pattern across a number of supervisees and various family situations. They may say, look, we've got a problem here in how we're relating to what it is, alcohol and drug service or a statutory service or whatever, and we need to really take this up at a higher level. So the supervisor's in a really advantageous position to be able to look at the patterns occurring across organisational boundaries and to try to reflect upon the level of intervention to deal with that. Okay, so I want to finish before I move on to the case illustration in the time we have left, to remind us of the beauty and the joy of a child, because I think it's the depth of commitment to children which I see as at the heart of why people continue to collaborate as effectively as they do, given the inherent difficulties that are there. So let's try and keep the picture of the child with us at all time. And let's now just briefly, oh, I've muted the audio rather than, no, that's what I meant to do. Okay, I think you still hear me at the back? Great, okay. For those of you who weren't here yesterday, I made a very fleeting reference to a little 5-year-old boy whose mother had a borderline intellectual disability and a long history of paranoid schizophrenia, and had spent 20 years in the back wards of a state mental hospital in Victoria. And I made a reference to this little boy who was very parentified, very concerned to look after his mother. And he'd said to me, as I said to all of you yesterday, in the middle of an intersection as I was driving him, "Who's looking after your children, Dorothy Scott?" And so this is a little boy who's very aware of what's happening in his world. This is the little boy who was aware of the name of his mother's psychiatrist and the next appointment, and his mother didn't know either. I was involved in this situation. I hope everyone can see it. The green might not be strong enough in retrospect. Of a situation when I, on a sabbatical leave, worked in an intensive family preservation program in non-government organisation number 2. So keeping Joan, as I'll call the mother, and Jay, her son, in the middle of the picture. Jay was conceived in a state mental hospital and has no contact with his father, but his maternal grandparents, Joan's mother and father, live close by, and in a way this functioned as a modified extended family, even though they were in separate dwellings, both in a public housing estate. And Poppy, the grandfather, was a very important figure in the life of Jay. When Joan was hospitalised with an acute psychosis, and Jay was 4, he went to live with his maternal grandparents, who found it very difficult to cope with his behaviour, and he then went to live with his uncle and aunt, Joan's brother and the brother's wife. So he had some time with the grandparents, he had some time with his aunt and uncle, who then couldn't cope with his behaviour, and then in the next little while he went to 2 foster families. So this is a 4-year-old child who's had 4 placements in 6 months. Think of a child you know and love, and think what they would be like after 4 placements in 6 months at the age of 4. It's not surprising then, when he's coming home from foster care, as Joan is discharged from hospital, that he comes back home with attachment and behavioural problems which a well-resourced parent with a lot of supports around them would find challenging. But we're asking this lady to cope with a child that is very, very demanding. He's bright, his verbal intelligence is above average, and he is not easy. So this is a bit of the service system, and I've highlighted the bits that were in interaction with me here. So first of all, I'm using this to illustrate that there's a whole lot of organisations we may not be aware of in the lives of the families that we serve. And I just want to highlight a couple of points in the short time I've got left, which are about interorganisational relationships. That he keeps going to the preschool that was related to the last foster family. And this is heading up to Christmas, so we don't want any more instability. So I, in the intensive family preservation model, am driving him each day back to his preschool, which is a long way from where he lives. But we have some great conversations in the car and some very clear and consistent limits, and we form a close relationship. Too close, really, because one day I'm making daisy chains with him with those awful little flowers, capeweed, and give his mum a break, and he said, "Dorothy Scott, I love you." and I thought, it's not me you should be loving. So, you know, that's not about interorganisational, but that's about intrapsychic. So the family is referred from statutory child protection to this organisation here, where I'm doing my sabbatical leave. This organisation has won the tender for the whiz bang intensive family preservation service, rah, 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 the new kid on the block, over these two organisations. Okay? So I've got to work with the foster care coordinator here. That's not such of a problem. But this is a 6-week intensive model. This family situation isn't going to be solved in 6 weeks. We're going to desperately need a local, long-term family support service. So here we are. I'm asking this organisation to get involved after I do the whiz-bang 6-week job. It was possible because I'd worked in another setting with the manager of that service. The interpersonal relationships transcended the damage that competitive tendering had done between the relationships. I would like to have spoken with the psychiatrist because Joan was on such extraordinary high levels of Largactil that she couldn't wake in the morning to care for Jay or get him ready for kindergarten. But Joan was not going to have any of that. This man has got the capacity to certify her. These people over here have got the capacity to remove her child. The last thing she wants is them coming together. So she's complaining about being doped up to the eyeballs, but I'm not allowed to even have a conversation with him or the GP, but I get to see the pharmacist because that's where she calls every day for a bit of a chat. And this is the man that I wouldn't have even thought of who really keeps an eye on Jay. So there are people in these networks we don't even know about who are the vital elements. So how do I help Joan raise the issue about her Largactil medication with the psychiatrist, given she won't give me permission to talk with him? I said one day, Joan, I've got an idea. Why don't we have a game where I pretend I'm the psychiatrist and you say to me what you'd like to say about how Largactil's making you feel in the morning? She said, I've got a better idea. Why don't I be the psychiatrist? So we had a great role play. And I was able to role play how to ask. She had very, very low literacy, but we also wrote down her words and my words and the words she'd agree with, and she was able to get that reviewed and changed. And so sometimes this is the sort of stuff you've got to do across the organisational boundary, and it's the stuff that you would do all the time. I really failed to engage with the school because it was getting close to the end of the year. They had had it. They didn't want to hear about what was going to arrive on their doorstep next February, but I wanted them to be aware, and I had the permission of the mother, to talk with the preschool people, a long way from this school, and to prepare for this child and family. But I couldn't get a conversation going there, and this all fell apart within a term because Joan started being very aggressive to other children in the playground that she thought were out to get her son. And in the end, paradoxically, Jay ends up going to the same special school that Joan went to, not because he had his developmental delay, but because his behavioural problems and the problems of his mother meant it was too difficult for that school to manage. The difficulty is, how do we work across some of these organisational boundaries in ways that holds the whole family together? I similarly had a difficulty. I wanted the school holiday program to realise something of his behaviour problems because he posed a risk to other children, serious risk. But Joan wouldn't let me have a confidential conversation with them, so I went with her, hoping that they would be awake to what was happening in front of us, but didn't pick it up, and then were quite angry and understandably with us when he took a golf club and hit another child, causing an injury, that they hadn't been informed about that and their duty of care. These are really difficult, serious issues. So I just use that as an illustration, and how with Communities for Children, we now have much better networks between preschool, schools, child protection, various NGOs, the school holiday program, and hopefully are strengthening the interorganisational networks with the part of the service system that is not specifically child-focused. So the question is, I suppose, is the glass half empty or half full? Well, it's not what's in the glass that matters, it's what's left in the bottle. And I think we've got a lot in our bottle. Thank you.